Thanks again for inviting me back to speak on Echo Rounds Part 2. And today we're going to be building on what we found in what we learned in Part 1 and really get into how to assess the individual valves and some other cardiac structures. So the objectives are to briefly review the principles that we talked about in the last talk. If there's anything that's unclear, I encourage you to go back to the YouTube video for Part 1 to review those topics. And then we're going to discuss cases. We're going to go valve by valve, structure by structure, discuss cases where 3D echo is helpful. We're going to talk about how to set up your images for the different structures, and then we're going to talk about how to use multiplanar reconstruction and how that can be useful in assessment of these structures. And again, I'll mainly be showing images from the Philips platform because that's what I'm most familiar with, but the principles that we talk about today will be applicable to the other platforms. So just to review, 2D image quality is going to affect 3D image quality. This is an example of a mid-esophageal view of the mitral valve, explaining through the valve here. And you can see the image is choppy, there's not good probe contact. And so if you take a 3D image of this, it's not going to look good. But if you improve your probe contact, you improve your 2D image, your 3D image is going to improve. That's really important. Again, shadows can't be solved with 3D. This is a 3D of the tricuspid valve, and it's very hard to see the leaflets. You can look at the images that it was acquired from, and they're shadowing from the aorta and the interatrial septum. And so that creates shadowing of the leaflets. You don't see them very clearly here. If you put that into 3D, the image is not going to be clear, and this 3D image isn't entirely helpful in and of itself. But if you use a lower window where you find better contact and imaging of the tricuspid leaflets, your 3D image is going to improve in quality. And then there's different image acquisition modes. The main one we're going to focus on for today's talk is the 3D zoom. This is a review of the basic 3D zoom workflow that we talked about in Part 1. So the first thing you're going to do is you're going to optimize your 2D image, get that looking as good as possible. You're then going to resize the image acquisition boxes for the 3D zoom, and we talked about how to adjust those box sizes. You want it to be as big as it needs to be to capture the structure of interest, but no bigger than that, because the bigger you make these boxes, while your image will be larger and you'll have more data within it, it takes more to process and your frame rate is going to be lower. Once you have produced the 3D pyramid, you're going to get something like this, and then we have to process that. So you're going to use the trackball to tilt the valve on fast. You notice there's a lot of smoke in the atrium. We're going to turn down the gain. Now we're able to see our valve, and then we're going to use the trackball and rotate Z to orient the valve in the proper orientation. For this case, the mitral valve, the aorta is at 12 o'clock. So this is a review of the workflow we talked about last in Part 1. So we talked a lot about the mitral valve on the last session, and we're going to build on that. So how do you acquire 3D of the mitral valve? We already alluded to that. My approach is to acquire it from the bicommissural view. This is usually at like 60 to 80 degrees. You see both papillary muscles here. You see the medial commissure, the lateral commissure, and the orthogonal image to that will produce the anterior-posterior plane, where you see the posterior leaflet here, and then the anterior leaflet closer to the aorta. I like this view because you see the whole of the annulus. You can make your box as big as it needs to be to capture the valve in whole. You also get a little bit of the aorta, which is helpful for orienting. And then when you do multiplanar reconstruction, which we'll talk about in a few minutes, this will put your bicom view in the green box and your grasping view in the red box. And that'll be helpful for later on. I'll show you. In terms of orienting, again, we already alluded to this. You have your pyramid. You're going to use the trackball to tilt it so that you see the valve on fast. And then you're going to use rotate Z to rotate so the aorta is at 12 o'clock or the valve is smiling. So this is an example of that smile of the mitral valve here. We see the lateral commissure and the medial commissures, and it kind of has this smiley appearance. You notice that the aorta in this image is not exactly at 12 o'clock. It's kind of at like 11:30 or so. So if the valve is smiling like this, I tend to prioritize that orientation rather than having the aorta at 12 o'clock, being dogmatic about that. I prioritize the smile. For patients with bioprosthetic valves or mechanical valves, they obviously won't have a smiling valve. But you try to put the aorta at 12 o'clock, the left atrial appendage at 9 o'clock, so that you have some way of orienting. And so we're all speaking the same language. And then just some review. Face crop is the cropping tool that I find the easiest to use. And the way it works is that when you hit the face crop button, it will create this theoretical cropping plane that you can then use the plane adjust to bring that cropping plane down. And then it will crop away some of the atrium so that you see the valve in better detail here. You won't actually see the cropping plane. It's just going to kind of crop it as you turn down that plane adjust knob. But I find this very easy to use. And just to review the mitral valve anatomy, there's two leaflets, the anterior leaflet closest to the aorta and then the posterior leaflet opposite to it. Each of the leaflets has three segments. So the one's more lateral, the three's more medial, and then in the middle is the the twos, the A2P2. So let's look at some examples. This is one that we've seen before, a patient that has a flail segment of P3. And when you map the valve and go through it, going from medial to lateral, you can really appreciate on the 2D image this flail segment of P3. But when you do 3D, it's obvious. You can see this flailing segment here. If you applied color would be coming from this area. This is an example of a patient who has significant mitral annular calcification. And you can appreciate on the 2D images just how the mobile portions of the leaflets here are really kind of short, don't open well, and there's tons and tons of MAC. But when you create the 3D, you can really appreciate how extensive and circumferential this MAC is and how small the opening orifice of the valve is. Cleft-like indentations are structures that are hard to appreciate by 2D, but by 3D is much more obvious. This is an example of a patient who has a myxomatous mitral valve. There's bileaflet prolapse here. There's this central jet of mitral regurgitation that we can see on the color image. And when we apply 3D, we often will notice this, that in between these posterior scallops here, there's this little indent here. And when we apply color, the color doesn't really seem to be coming through that indent. It's really central. That's what we saw in the 2D images. And the question is this clinically relevant or clinically significant? We see this quite frequently, actually, when we do 3D images. And so this patient actually came to the lab for a mitral transcatheter edge-to-edge repair. We tried implanting a clip in between the anterior and posterior leaflet, as shown here. And what you notice is that while the overall regurgitation has gone down, we've actually now opened up a jet in this indent here. By pulling the leaflets together on this side of the indent, we actually opened up and pulled that indent open where it was not open before. And when we interrogate that using multiplanar reconstruction, it almost looks like there's a jet going through the leaflet. It's not going through the leaflet, so it's like beside the leaflet. It's in between the indents here. And so while it may not be relevant or easy to see on 2D imaging, on 3D imaging, we get a hint that there's something there. And then that helps us with our procedural planning. In this case, we didn't deploy this device. We worked the patient up for a different strategy for fixing their mitral regurgitation because we weren't satisfied with this result. Paravalvular regurgitation is another area where 3D is helpful. This is an example of a patient who has a mechanical mitral valve. You can appreciate there's this jet, highly eccentric of paravalvular regurgitation. So the way we try to understand paravalvular regurgitation is really by increasing our angle by 30 degrees or so to try to get a sense as to where these jets are coming from and how extensive that is. And by going up in this fashion, you kind of paint a picture in your mind as to what this valve looks like and how extensive the paravalvular leak is. What's beautiful about 3D is not only can you produce these really lovely images of a mechanical mitral valve, you can see the occluders opening very well here, but you really see right away just how extensive this paravalvular, it shows you just in one shot how extensive the paravalvular leak is. It starts kind of at 3 o'clock, it goes to about 6 o'clock, and then there's also this jet at 8 o'clock. Here. So it's quite extensive, and it just shows you all in one shot how extensive that leak is. In this case, for this patient, we applied a bunch of plugs. So these are examples of AVP2 plugs, and we started about 5, and we were able to bring down the patient's paravalvular regurgitation, though there is still some residual leak around 6 o'clock and a little bit at 8 o'clock. And then endocarditis is another area where 3D can be helpful, again, to appreciate the big picture and see the extent of it. This is an example of a patient who has a bioprosthetic mitral valve, and when you explane it, you can see that there's a vegetation along the prosthetic annulus as well as a more linear, highly mobile component. And by using 3D, we can see again that there's this large vegetation on the annulus here, and you appreciate the mobile portion that goes into the valve in diastole and then in systole comes back up into the atrium. So multiplanar reconstruction, we already kind of alluded to this, is a very powerful tool that you can use with 3D imaging. So you will find it by using Multiview on the Philips platform. On the 3D tab, it's right here. And the reason why it's so powerful is that it allows you to take any 3D data set. So any 3D data set that you've saved, you don't have to save it as an MPR and then acquire it. Any 3D data set that you have, you can do multiplanar reconstruction. And what you can do is you can reconstruct and display 2D images, any 2D image that is theoretically possible in this 3D data set, you can reconstruct it by using NPR. And this can be done live or in post-processing. I'll show you some examples of how this is useful. So just to orient you, when you create this 3D image and you hit NPR, it creates these 3 boxes, and we're going to go through them step by step. So these are the 3 boxes. First box is the green box. This will be where your image was acquired. So typically we acquire it in a bicommissural or bicommissural-like view, and that's what we see here. This green box will correspond to the plane on the red box where this green line is, and on the blue box where this line is, as well as on the 3D image, this is where the green box is acquired from on the 3D image. Now your red box reflects the 90-degree orthogonal image to that, so that would be like your long axis or your grasping view here. And on the green box, the red image is acquired in this plane, on the blue box in this plane, and on the 3D image in this plane. Kind of not quite in this image, we're going to fix this, but kind of perpendicular to the coaptation of the leaflets. And then the blue box is this theoretical short axis that's created, and this is sort of how the blue box would be created by default. So let's understand what happens when we start adjusting these lines. When you take the red line, for example, and let's say we decided to move more laterally here, well, what will this do? Well, this will move the red line in the other planes, like the blue box or the 3D, more laterally. And that's what you see here. It's obvious on the 3D image that we move more laterally away from the middle. And what it will do is it will change the red box to reflect that new position. So in this case, we're more lateral. This is probably showing area of coaptations in the ones, more laterally. Let's say if we take that lateral red line, let's say we move it more medial. What's going to happen now? Well, it's going to move that red line in the blue and on the 3D image more medially. And now we're going to see coaptation at the medial aspect of the annulus between the threes, between A3 and P3. Let's say we do something like this, where we drag our blue line down to kind of see the ventricle. Well, what will that do? Well, that will drag the blue line down in your red image here, and it will create kind of a short axis-like image of the left ventricle. I don't do this routinely, but this is just for illustrative purposes. And then let's say, we're not happy with our bicom view here. This isn't really a good bicom. We can do better than this, and we want to fix that. Well, one of the ways we can fix that is by rotating our planes in the blue box, so that now this green line is truly lined up, is parallel to the commissural plane, and the red line is more perpendicular to the commissural plane. And this produces a better bicom, and we'll get this looking better in just a minute. And let's say, we get really wacky and we just continue rotating these, these planes in the blue box. Well, now we can flip it. So now our green box, instead of being a bicom view, is now showing a long axis view, but it's kind of flipped. And then the red box is now showing a bicom view, but again, it's kind of flipped. Your orientation is off from how you're used to. So while NPR can be really powerful, it can also be a bit overwhelming in terms of how you display your data and how you stay organized. So I'm going to show you an organized approach on how to do that. The way you're going to get into NPR, as I said, is you're going to press that multi-view button or NPR on your system. And then my step-by-step is summarized here, is you're going to lock the planes, you're going to set the reference, you're going to plane adjust, you're going to rotate Z, and then you're going to adjust the lines. And if you have no idea what these terms mean, you're going to understand in just a few minutes as we break it down step by step. But this is my process summarized. So on the touch screen, you're going to hit the multi-view button here. That's going to take your 3D image from the 3D image to now this multi-view where we have our green, red, and blue boxes, and our lines are here. Just to orient you to the touchscreen for multi-view, it's kind of similar to the 3D touchscreen. You're going to have layouts here, and this is going to display or on the top screen show you how your boxes are displayed. The default is the one that has 3 triangles, one of which is a 3D triangle and a square. I encourage you to stay here, but you can pick these different displays if you so choose. They're similar to the 3D layouts we talked about last time. Lock is a very useful tool. This will lock your planes so they stay perpendicular to each other. And this is really important when you're first starting to use NPR. So I encourage you to hit that right away. Reference will change the 3D image to whatever plane you pick. So if you pick the blue box, it will make the 3D image lined up to looking at what the blue box is. If you pick the green box, it will change the 3D image to be what you're looking at the green box. And then view line will get rid of the red, green, and blue lines on the 3D image if you want to display your data a little bit more differently. So let's talk about how we use NPR. As I said, my first step is to lock. I lock the planes. There are going to be times when you'll want to have the planes unlocked, but I'll say when you're getting started with NPR, 95% of the time, you're going to want the planes perpendicular 90 degrees to each other. They default as unlocked, but if you hit the lock button, it will lock them 90 degrees to each other. So I encourage you to do that. The next thing you're going to do is you're going to set the reference. So that's under this reference part here. And it defaults as reference 3D. That's the 3D image that you acquired. We're going to want to set the reference to blue, and I'll show you why in just a second. It's going to lock basically your blue plane and your 3D image to each other. So this is an example of us referencing blue. You can see these were where we started when we hit multi-view here. We have a nice 3D image, and then we reference blue, and now this 3D image looks terrible. It's like rotated in the wrong orientation. It's kind of cut off here. But this is a little short-term pain for long-term gain because we're going to want these blue and the 3D images to look the same. And so we're going to fix this. The next step I do is I adjust the plane adjust knob. I give a little bit more room above the atrium, and I'll show you what that does. And then the rotate Z is going to be important for orienting your image. So what plane adjust will do is once you hit the reference button, it will look at one of the planes. So in this case, it's looking at the blue plane here. Now you can see we're kind of cutting off the valve a little bit. So what I will do is I'll use the plane adjust knob to bring this dash line up just a bit, and then that will give you more room in the atrium to see your valve. So already this image is looking better. The next thing we're going to do is we're going to want to have our mitral valve oriented as it was originally, with the aorta roughly at 12 o'clock or the valve smiling. So you're going to use the rotate Z knob. And you'll notice that when you rotate Z, this will not only rotate the 3D image, but it will rotate the blue box image as well. So now they're lined up against each other. So our blue box is going to be oriented in the same plane as our 3D image. And this is what we want. This is the point of setting the reference. And then after that, you're going to adjust the lines, and through a step-by-step fashion, we adjusted these lines. So now this green box is a perfect bicom, this red box is a perfect grasping view, and our blue box is a nice short-axis image of the valve that we can use for measurements. So I'll show you how we do that. I usually start with the blue box, and the reason why I do that is I want to have the green and the red to be a good-looking bicom and a good looking grasping view. So you can see here, if we look at this image, let's see the lines show up. Yeah, they do. Sweet. So if we just go back for a second, the green line here is not along the commissural plane. It needs to be rotated a little bit, and it needs to be translated a little bit. And that's why our bicom image doesn't look good. We're actually cutting through the anterior leaflet here. That's what you can see. So in order to fix that, it requires a little bit of countering and then a little bit of translation. Sorry about that. Here, a little bit of countering and then a little bit of translation. And so now this green line is lined up parallel to the commissural plane, and the red line is perpendicular, and that will make this bicom image better. So that's where I started with first. Then I adjust the green box, and all this requires is a little bit of countering of the blue line. So that will be perpendicular. And if your planes are locked as they should be, now your red line is going to be perpendicular. Sorry, your blue line is going to be parallel to the annulus and the leaflets. The red line is going to be perpendicular. And then we're going to adjust our red box. And this requires a little bit of clocking as shown here to make the blue line parallel to the leaflets and the annulus, and the green line perpendicular. And so then once you've made those small adjustments to the lines, you now have a perfect bicom that you can use for analysis, perfect grasping view, and your short axis is lined up to then take some measurements. So this is the protocol summarized. And if you get lost, as can happen when you're first gaining experience with NPR, you can reset by using the reset multi-view button, and this will reset you back to home base, where you can then start over. Now I'll show you some strengths and limitations of NPR. It's a really powerful tool to reconstruct any 2D image within that data set. So this is an example of a TE that was done for a patient who had a previous mitral transcatheter edge-to-edge repair and then developed significant mitral regurgitation afterwards. And the probe contact was really challenging with this patient. Sometimes for 15 seconds, we would get a good quality image, and then the probe would move, and then the contact would be poor. And so just perhaps by luck, a good quality 3D data set was obtained. And you can see it's not oriented in the way exactly we would want, but it's a good starting point. And what we can do then is with multiplanar reconstruction is we can go through and we can actually dissect this valve and find where that clip was, which we couldn't see well with the 2D imaging. We could find where that clip was, and we could see it's no longer attached to the anterior leaflet. And we had a similar data set which had color. We were able to deconstruct that as well and understand where the clip had detached, and then that informed our strategy for the next step in trying to help this patient. One of the drawbacks of multiplanar reconstruction is that compared to the 2D image with X-plane, your frame rate is going to be lower and your image quality is going to be lower. So that's something to be aware of. This is basically the same image produced with NPR versus acquired with X-plane imaging. We've gone from 32 hertz to 22 hertz, and that's because the 3D data set has more to process. And then when you deconstruct the images, it's not as clean as with the 2D image with X-plane. So that's something to be aware of. One of the strengths is that it allows you to take measurements. And so for the mitral valve, one of the measurements we measure routinely with mitral valve pathology is measuring the area by planimetry. And this can be attempted by using different views on transthoracic and transesophageal. But with NPR, you can be more confident you're actually at the leaflet tip. So this is the protocol that I use summarized. We'll go down step by step. So with your NPR, once it's lined up perfectly, you can freeze the image. You can see here the mitral valve is closed. So we're going to use our cine function by using the trackball and left clicking to rotate through where we see the leaflets open. And so we see the leaflets open here. So this would be a good place to measure the mitral valve area. We're then going to move our blue line down to the leaflet tips as shown here. And then often there's a little bit of rotation of the blue line in the red box to make it so that we're at the orifice and we're not too low below the posterior leaflet as shown here. And what this will do is this will create a short axis image of the mitral valve orifice at the tips. And then we can use the layout function here to highlight one of the images. So we can make one of the images bigger, and that's the use of this layout function with highlighting this big triangle. And then we can use layout configuration. It defaults to showing the 3D image as the large image, but if we use layout configuration with the blue triangle, it will make the blue box the big box. And then we can measure that by using measure on our touchscreen continuous trace to measure the mitral valve area. And so don't worry if not all of this is sticking right now. One of the benefits of having this on the YouTube channel is this will be something that people can go back to if they want to review how to take these measurements. Another structure or another component we measure routinely is the mitral valve annulus for mitral valve pathology. And so I often do this in the same plane that I do the mitral valve area. In truth, we should probably measure it in both systole and in diastole because the mitral valve annulus is a dynamic structure. When they measure it at CT, they actually measure it at 5 points. I just tend to measure it at 1 because we're just getting a ballpark for how big the annulus is. And then so I measure it in the same plane because it's just easy. I translate the blue line up as shown here, and then there might be little bits of rotation to make sure that we're lined up with the annulus, and then it produces this saddle-like shape in the blue box, which we can then highlight and measure. One of the things that I think trips people up about the annulus is that when you line it up in the red box, this line looks good. It looks like we're right along the annulus here. But then when you're at the green box, it looks like we're too high. So one of the temptations is to try to bring that blue line down in the green box, but then you notice that you're going to be too low in the red box, and you're kind of chasing your tail. So I remind people that the annulus is actually a saddle-shaped structure where the AP, the anterior-posterior plane, is actually higher than the medial-lateral plane. In the green box, you're seeing the medial-lateral plane. So if it's a little bit high, if it looks high in the green box, I accept that if my red box measurement is good. In truth, there are additional 3D softwares that will actually take into account the saddle shape of the annulus, but the most default technologies will just kind of measure it in one plane as shown here. And then again, you can highlight the annulus and then trace it. Okay, so now we're going to move on to talking about the tricuspid valve, building off what we've talked about with the mitral. This is a 3D image of the tricuspid valve. There's a lead going through the posterior septal commissure here, and there's also a little bit of an RA lead shown here. It's a nice image of the tricuspid valve. So some of the uses of 3D for the tricuspid valve are assessment of tricuspid valve regurgitation mechanism and extent, sizing of coaptation gaps, localization of pacemaker leads, and then measurement of the tricuspid valve annulus like with the mitral valve. This is an example of of tricuspid valve anatomy. Typically has 3 leaflets, an anterior leaflet here, a septal leaflet near the septum, and then a posterior leaflet here. In truth, we know that patients can have anywhere from 2 to 5 or more leaflets as we better understand the tricuspid valve, but typical configuration is shown here. In terms of mapping, which is a concept we talked about in part 1 with mapping the mitral, you can also map the tricuspid. And again, the concept of this is starting in an area where you know, and then obtaining an orthogonal image to better assess the pathology. So by starting where we know, we use this inflow view on transesophageal echo. This would be analogous to the short axis view of the tricuspid valve on transthoracic. And what this does is this displays, like where this green line is, the anterior posterior plane of the tricuspid valve. And you know you're anterior because it's closer to the aorta. So that's kind of my home base. And then the orthogonal image will display a 90-degree image, which will show coaptation of the leaflets, so anterior and septal or posterior and septal, depending on where you're cutting with this X-plane image. So this is an example where the line is more posterior, away from the aorta, and this is showing coaptation between the septal and the posterior leaflet, and this is kind of where our lines would be on the cartoon. If we move that X-plane image more anterior, as shown here, this shows the coaptation between the septal and the anterior leaflet, as shown, and this is kind of where our planes would be in the cartoon. And so you could start by going posteriorly with your X-plane imaging, again, starting from where you know where you are. So we know we're posterior here, and that produces a septal leaflet always on the left, and the posterior leaflet always on the right. And so we can go from posterior to the middle of the valve to the anterior aspect of the valve and see how the coaptation is between the leaflets by mapping the valve in an organized fashion. When you're in the middle, it's often hard to know, is this anterior, is this posterior? Often there can be multiple scallops. So is it an A2 or is it a P1? I often just call this lateral in this position here, because without dissecting the valve further, it's hard to know exactly where you are when you're in the center of the valve. And then likewise, you can apply color when you're mapping. So by going from 2D to color imaging, and we can appreciate here how there's not much color coming from the posterior septal commissure, but as we go more central, there's a central jet here, and it seems to extend to the anteroseptal commissure as shown here. And you can do this with transthoracic as well. This is images from our lab where the sonographer mapped the tricuspid valve using the short axis here. Again, closer to the aorta as anterior and away from the aorta as posterior. So that's kind of your home basis to know where you are. And then by applying your X-plane here, it will produce the septal on the right and the lateral on the left. And you can get into the same orientation as TE by using the right invert. I'll show you that in a second. In this case, they're cutting through the patient has an ICD lead here, and we can appreciate how the septal leaflet is really impinged and just locked up against this ICD lead. And there's a gap where my cursor is here where the lateral leaflet does not coapt well. And when we apply color, we can appreciate how there's a jet coming from this gap, and there's a Pisa shell there without even dropping the baseline. And so this is an example, again, of mapping the tricuspid valve on transthoracic, starting posterior here where this line is, and this is showing coaptation. The sonographer used the right invert here, so instead of being at 90 degrees, it shows the orthogonal image at 270 degrees. All this does is it puts the septal on the left and the posterior on the right, which is how I like to display things. And then we can go through and map and see the coaptation. Coaptation, septal posterior looks okay. In the middle of the valve, there's this lead here where the leaflets are both touching. And then anteroseptal, this looks okay. And again, color can be applied here, and we see most of the color is central to the valve and around the lead. This isn't showing impingement like in the last example. This is more just leaflets are interacting with them. So how do we acquire 3D images? Again, we're going to be showing mainly TEE images. Your views for this are the mid-esophageal, deep esophageal, or transgastric. And so again, like with the mitral valve, you want to make your boxes as big as they need to be to see the valve, and also have some orienting structure like the aorta there so we can help to orient our valve, but also not make them too big so as to drop the frame rate. So when we acquire from the mid-esophageal view, this is an example of that. And this is the example where you got a lot of shadowing from the interatrial septum and the aorta. And depending on the patient's anatomy, this may be a problem. You can try to get around this by using your knobs. But if you can't, then this might be just the best 3D image you can produce in this window. But in the same patient, by going deeper and looking through the right atrium, so you can appreciate how the probe is now looking through the right atrium here. We're now looking at the tricuspid valve without all that shadowing from the aorta and the septum, and our 3D image works better. So this often is a little bit deeper into the esophagus and a bit of anti-flexing to produce this sort of window. And then the transgastric view can also be used to produce 3D images. This is taken from the stomach with anti-flexion applied, and we can appreciate how there's this lead in the middle here on the 2D imaging and then a coaptation gap, and it produces a similar looking image by creating 3D. In terms of orienting your tricuspid valve, I would say compared to the mitral, there's not as much trackball that you have to use. It's maybe a little bit of tilting to see the valve on fast, a little bit of gaining up or down to see the leaflets, and then a little bit of phase crop to crop away the atrium using the same principles we talked about with mitral. The main difference is that you're going to be rotating Z to have the aorta at 5 o'clock as is shown here. And the reason why that's important is that it will then mimic your transgastric view and your 3D view. So this is the interventional way how we like to display the tricuspid valve, so that when we go into the stomach and transgastric, we can see the anterior leaflet here at like 7 o'clock, posterior at 10, septal at like 2. And then so by having it in the same orientation, the 3D and then the transgastric are speaking the same language. That's why we like having this aorta at 5 o'clock as shown where my laser is. So this is an example of using 3D for assessment of a pacemaker lead and tricuspid regurgitation. You can appreciate how without even applying color, there looks like there's this gap between the posterior and the anterior leaflets, which isn't necessarily related to the pacemaker. The pacemaker is more touching up against the septal leaflet here. But when we apply color, we see regurgitation all along the middle. So we can try to understand what the mechanism is by using multiplanar reconstruction. And so what we've done here is we've lined up our red line along the pacemaker lead, and we can appreciate how this pacemaker lead seems to be interacting with this septal leaflet as shown here. And then when color is applied, there's color coming through this area, part of which is related to pacemaker lead interaction, but part of which is also related to that gap between the anterior and the posterior leaflets. Another time that 3D is useful is in assessing the coaptation gaps. So this is an example of a patient who has a torrential tricuspid regurgitation. There's large coaptation gap in the middle here, and there's a lot of color coming through all through the valve. So one of the ways we assess coaptation gaps is by using the transgastric view. But you can see for this patient, we were able to see the anteroseptal coaptation gaps quite well, but we couldn't see the posterior ones. They kind of just phase out, and we can appreciate how we're not quite on fast with this valve in the transgastric view. So the question is, how big were the gaps posterior septal? Already these gaps are very, very large. So with 3D in the mid or the deep esophageal view, we were able to produce this 3D image here, and you can appreciate how big the gaps do extend towards the center of the valve and posterior septally. And when color is applied, there's a lot of color coming through these gaps. And with multiplanar reconstruction, you can actually go through and map along and measure the gaps here. So this is an example of how we've oriented. I'll show you how to orient this in just a second, where we put the red line between the anterior and septal plane. So it's perpendicular to how the leaflet should be coapting. And what we can do is we then in the red box see that gap here, and we can freeze the image and measure what the gap is. This was 10 millimeters, similar to the transgastric. And by moving the line more posterior to the posterior septal commissure, perpendicular to that coaptation plane, we can again freeze the image and measure the coaptation gaps between here. So this is an example of using 3D and NPR to measure coaptation gaps. So how do you set up your tricuspid NPR? Well, it's going to be quite similar to the mitral. You're going to start by locking your planes. You're going to set reference to the blue plane adjust. So those steps are similar. You're then going to adjust your lines, and then I encourage you to rotate Z later on in the protocol because it's going to require fixing the tricuspid valve more than with the mitral valve, and I'll show you why. So we have this beautiful 3D image. We're going to press NPR, and it's going to produce in the green box the plane, the image where we acquired it from, kind of this RARV inflow view, and then the orthogonal image is going to be in the red box. We're going to do the same steps where we're going to lock our planes. We're then going to set the reference to blue as we did last time. And you'll notice that when we set reference to blue, we have this beautiful 3D image, and now it looks terrible. And that's because we need to fix this blue plane. It's created this 3D image from this blue box that we need to fix. So again, I usually plane adjust just a little bit to give me a little bit more room in the atrium. Didn't really do much to fix this valve. I usually start with the red box here. With my planes locked, I will rotate the blue plane to be along the tricuspid annulus and the tricuspid leaflets. You can see just how much we have to rotate this plane to fix this image. And you can see immediately this 3D image is looking better because now the blue plane is lining up parallel to the tricuspid annulus and the leaflets. So to make it look even better, we're going to fix the green box next, and it requires a little bit of clocking in this example here to make the green line up against the tricuspid annulus, and now our 3D image is looking better. And at this point, I would recommend rotating your image. The aorta you can see here is at 3 o'clock where the star is, and if you use rotate Z, you can bring the aorta to 5 o'clock, which is where we typically want to display the how to display the tricuspid valve. And then finally, the last sort of step I do is in my green box here, just because I'm a bit of a perfectionist, I like to rotate these so that the green line is now parallel and is sitting exactly along the anteroseptal commissure, and then the red line is perpendicular to the commissure, and that will improve your inflow view, and that will make the red box more accurate to how the leaflets are coacting. And like with the mitral, you can measure the tricuspid annulus. When your MPR is set up, as I've shown you, you can then freeze the image. I tend to measure it in diastole. You can then adjust your planes. It often is a little bit of a rotate, as shown here, and then it's a little bit of a translation up to the tricuspid annulus. That will produce this sort of circle here that you can then trace. You can trace it with area measurements to measure an area, and anything more than 10 centimeters squared is considered dilated. Or you can measure a perimeter, and we use that perimeter to calculate a perimeter drive diameter. So when we replace tricuspid valves percutaneously, the valves are usually circular. The annulus is often not circular, it's oval. But when we replace the valve, it sort of stretches the annulus into a more circular shape. So we see kind of if we conserved what that perimeter was, when we assumed it was a circle, that's the reason why we often measure perimeter. Because then we can calculate what an average diameter if that perimeter was then stretched into a circle-like shape, and then that will inform valve sizing. You can also measure the anterior-posterior and the septal-lateral dimensions as well. Those can be helpful for reporting. In the last few minutes, we'll briefly talk about aortic valve assessment, ASDs, and left atrial appendage assessment. So this is an example of an aortic valve in 3D. And just to orient us, this is an example of TEE on the left, where the non-coronary cusp is at 10 o'clock, left coronary cusp at 2, and right coronary cusp at 6. Your guiding light is going to be that interatrial septum. Wherever you see that, that's going to be your non. Then your left is closer to the left ventricle, right is closer to the right ventricle. And on transthoracic, the orientation is shown here with your interatrial septum and non kind of at 8 o'clock, your right at 12, and then your left coronary cusp at 4. So we'll again be showing transesophageal images. This is an example of a short axis of the aortic valve, usually taken around 45 degrees or so. And you can X-plane through the valve to get a sense as to what the coaptation is between the different cusps. So by X-planing between the left coronary cusp and the right coronary cusp, you get a sense in the long axis what the coaptation is between these cusps. But you'll notice that this line is not exactly along the coaptation plane. And I'll show you how with MPR you can actually fix that and assess that. And with cutting through the non-coronary cusp and right coronary cusp, again, you get a sense of what the coaptation is like between these cusps, but it's not perfect perpendicular to that coaptation plane. So to acquire a 3D image, I usually do it from the short axis at 45 degrees. And the reason why I like this is that, when you've set your boxes and you have a box that is big enough to include the whole of the valve as well as some of the interatrial septums that you know where you are, when you then hit 3D zoom after lining up your boxes, it will basically orient your image in the same way as the short axis. And I find that very helpful with your non at 10, your left at 2, and then your right at 6. This often, you don't have to do any really trackball work. There's just some face cropping really just to get rid of the a little bit of the aorta so that you can see your leaflets better. But there's not much manipulation once you acquire it from the short axis. So I find that helpful. And then you can use this dual view to show the aorta from the aorta side or from the LVOT side. You can apply color here. I have to say, I often find that the 3D quality of the aortic valve is not that good because the cusps are thinner. So I find this is not entirely helpful in and of itself. But there are cases when it can be, specifically when you use NPR. So this is an example of a patient that has this kind of redundant looking aortic valve. It kind of has this like multi-scalloped kind of cusps here. And they have significant eccentric aortic regurgitation that we wanted to understand the mechanism. When we did 3D, this is what we produced. And I don't find this very helpful at all to like understand the mechanism of this valve compared to the tricuspid or mitrals that I've shown you. But one of the ways that you can assess this valve better is by using multiplanar reconstruction. And again, once you hit the multi-view button, there's not much manipulation you have to do. Your short axis is going to be in the green box, your long axis is going to be in the red box, and you're basically ready to go here. And your goal for using NPR is to see what is the coaptation between the different cusps. You remember when we used X-plane, we weren't quite perpendicular to how the cusps collapsed. But with NPR, we can be. So this is an example here in the green box where we've put our red line between the non-coronary cusp and the left coronary cusp. And we can see here that these cusps look kind of like floppy and redundant. But when we apply color, there's color coming from below the valve, but not really through this area here. Not much malcoaptation. So it doesn't seem like the problem is here, but it goes in this direction of the NCC and LCC. Okay, so let's say we now move the red line to be perpendicular between the coaptation of the non-coronary cusp and the right coronary cusp. Again, we can appreciate how these cusps are kind of like multi-scalloped, but these seem to coapt pretty well. And when we apply color here, there's no color coming from this area here. So now what about if we move our red line to assess the coaptation between the right coronary cusp and the left coronary cusp? Well, here, this looks unusual. This right coronary cusp here looks a little bit short. It's kind of retracted up a little bit. The left coronary cusp also kind of looks a little bit short here, and it prolapses down. So there's this gap that you see between these two cusps, specifically at this commissure. And when we apply color here, we can see this eccentric jet of aortic regurgitation actually originates from this area of malcoaptation. This wouldn't be possible to see on 2D imaging, but on 3D, by lining up your planes exactly perpendicular to the coaptation point, that's one of the ways you can use 3D and NPR to assess the aortic valve. Another example is with aortic valve measurements. So this is an example of a patient with a bicuspid aortic valve with eccentric aortic regurgitation that was being considered for a surgical repair. And when we apply 3D, again, the raw 3D image is like, it's not helpful. This doesn't add any useful information to what we saw in 2D. What's interesting is that when you use NPR, you can then adjust your planes to take all sorts of measurements of this valve that can be helpful for the surgeon to repair this. So this is an example of lining up along the non-coronary cusp, and we see the non-coronary cusp here, and then we can measure this. We can measure the cusp lengths of the different leaflets. And then one of the things we didn't talk about on the layout was this one here that has 9 boxes and 3 triangles. Well, what does this do? So in order to use this function, you need the structure of interest, whatever you want to assess, to be in the blue box. So one thing we're going to have to do here is change the short axis of the green to make the blue in the short axis. And one of the ways you're going to do that is just by rotating your blue line to basically make it along the short axis. So you first have to do it here, and then your green box will change to something like what's in the blue box, and then you'll have to rotate that to make your blue box. It requires a little bit of playing around to understand exactly how to do that. But once your blue box is in the short axis, and you use this function here that creates these 9 boxes, what it will do is it will create 9 short axis images in between these dashed lines. So it'll start in the middle. This middle one will be where this line is. And then it creates 9 short axis images between these dashed lines. And this can be pretty helpful. Like in this case, I'm trying to see what the aortic valve area is by planimetry. And so what I can do is I can create 9 images from the cusps to like a little bit past the tips here, and then I can see where I see the tips best seen, and then I can trace what I think the area is. Rather than having to move my lines up and down, it can kind of display 9 slices all at once, which is kind of helpful. And then you can expand these dashed lines to take even more measurements. So you can expand it down to include more of the LVOT and the sinuses and the ascending aorta. And you can actually measure the LVOT dimensions here, and the LVOT area is shown here. You can measure the distances between the different sinuses as shown here. And you can measure the dimensions of the ascending aorta here all in one image. So you can take many measurements. And Dr. Ahmed Omran gave a great talk and the talk is up on the YouTube channel, talking about these measurements and how these were developed over time to help surgeons understand how and if they can replace the valve. So if you're interested in learning more about this, I encourage you to visit his talk. So lastly, we're going to talk about ASDs and left atrial appendages. This is an example of a secundum ASD with left to right shunting by color Doppler. And so for 3D, I keep it simple. I just pick a view wherever I can see the ASD well, and I create a big sector to have images in there that will help me understand kind of where the ASD is relative to other structures. This is an example showing the secundum ASD. So we see our thicker atrial septum here, and there's a thinner atrial septum, and then in between the two, there's this defect here. That's our ASD. That's our hole. And so you can use dual view here to produce views of it from the right atrium and the left atrium. I don't fuss too much about orienting these images, but if you wanted to, you can put the mitral valve kind of around 6 o'clock or so, because then this will inform what the superior, inferior, anterior, and posterior planes are. But I don't find these images, aside from looking interesting, to be too helpful. And then you can apply color here on the dual view, and we can see color moving away from the left atrium into the right atrium. These kind of produce these like Rorschach ink blot looking images, which make me contemplate where I'm at right now. But so again, I don't find this too helpful, but what ends up being helpful is the multiplanar reconstruction to accurately size the ASD. And so with this, you're just going to hit multi-view, you're going to lock your planes, and you're going to freeze your image as shown here to where the ASD looks the biggest. And it's going to require a little bit of adjustment of the lines to make the blue line line up with the orifice of the ASD. You're going to translate it down so that it lines up there. And then what that will do is that will create a short axis image of the ASD, which then you can measure. And this will be more accurate than measuring in 2D, because depending on how you line up your image on 2D, you may underestimate the size of the ASD. Whereas if you create a perfect circle as shown here, you can really be accurate on what the ASD sizing is, and this will be helpful for closing the ASD. Lastly, we'll just mention about the appendage. Appendages can be closed to help reduce patients' stroke risk in patients who are unable to tolerate anticoagulation. There's different devices that can be used, but sizing the appendage is an important step in deciding how to close it, which device and what size. And so typically we do that in 2D by taking measurements at 0 degrees, 45, 90, and 135, measuring the orifice and the depth. But depending on how your probe is lined up, you may actually underestimate these dimensions by not having it lined up perfectly. So 3D can be used to take measurements, and I basically just pick an angle like 45 or 90 wherever I see the appendage well, and I create a big enough box to have some orienting features like the mitral valve here, but also just so I can see the whole of the appendage. And the 3D in and of itself produces an image like this, which just kind of shows the sock and the orifice of the appendage. And I don't find this very helpful at all. But the NPR is what's actually helpful, like with the ASD. And so when you enter NPR, it's going to produce line and an image like this. You're going to rotate your plane so that your blue is going to be along the orifice of the appendage. It often requires a little bit of translation, as shown here. And so you'll move the blue plane to be at the orifice. Your red and your green lines are going to be perpendicular. And what that's going to do is in your blue box, it's going to produce a short axis image of what the orifice of the appendage looks like, which then you can freeze, maybe make some final adjustments to the lines to line it up perfectly. And then you can measure the minimum and maximum dimensions and area of the appendage, which will be helpful for sizing. Depending on the device, that will affect where exactly you measure. If you measure at the orifice, which is typically where the circumflex artery is, or a little bit lower at the neck, it'll just depend on the device you're measuring. But the principle is there. This is how you use NPR to take the measurements of the appendage. And then post procedure, you can use 3D to visualize the device, and we can apply color to see if there's any leak around the device. So again, I know it's a lot, but one of the benefits of having this on the YouTube channel is this will hopefully be a resource for people to come back to if you want to learn more about 3D. And we talked a lot about multiplanar reconstruction. I find 3D helpful in that it provides a big picture perspective, but you need to correlate this with a good 2D assessment, and I can't say that enough. Your main decision points are going to be made based on 2D, but 3D kind of puts it all together, and they're very complementary to each other. Each valve has its own standard orientation, like the mitral has the aorta at 12 o'clock, the tricuspid at 5 o'clock. So I encourage you to learn what that is so that we're all speaking the same language. And then having an organized approach to NPR is going to allow you to better understand pathology. You can see with the aorta example, how we wouldn't have understood exactly why that valve was leaking without being able to deconstruct it with NPR. In order to stay organized and be comfortable, it requires practice. So I encourage you to practice. And if you have any 3D data set on your machine, you can then go back and dissect. You don't have to do the NPR live. It can all be done in post-processing. And then, we talk a lot about measurements, like measurement of valve area, annular area, ASD, left atrial appendage size. These are all just variations of the same thing. It's all just lining your blue line up on an orifice that you want to measure. It's actually quite simple, but it can be intimidating when you're not comfortable with that. But if you keep it simple and just think about how am I going to line up this blue line along the orifice I want to measure, that's really all we're doing when we're taking these measurements. And so with that, I thank you for your attention. I hope it was helpful, and happy to answer any questions.